doing medicine, it's kind of one of the professions in the Caribbean where bright young people are channeled. And so initially, I resisted that idea. I wanted to be a writer. And I remember very clearly that Presentation College, San Fernando, could not get a literature class together. We couldn't get four people to do literature at A levels. We had enough for economics and history, but no literature. So I went into science.
Hello, folks. Welcome to Season 10's TRINI Corner series, brought to you by the Consul General of Trinidad and Tobago, Mr. J. Andre Laveau. I'm Ozzy Stewart, as you know, and very, very grateful to have you here with us for this thank you tour of mine, giving flowers to deserving impactors within the Trinidadian diaspora. So please like, follow, share, all those wonderful things. And don't forget to drop a comment. Please drop a comment. Check out our new donate and membership pages for our after show ITC. Look out for that. On this episode, I'm shining light on our esteemed Dr. Farley Cleghorn, who has given his life to study, care, and cure of the human condition medically and otherwise. Listen up. This is where I get into who Dr. Farley Cleghorn is and why you should know about him. As a fellow TRINI, Dr. Farley R Cleghorn's illustrious career spans over 3 decades at the forefront of global health, infectious diseases, and epidemiology. Born in Trinidad, he embarked on his medical journey at the University of West Indies, otherwise known as UWI, graduating with honors and a surgery gold medal in 1982. Early in his career, he delved into hematology at the Port of Spain General Hospital, focusing on lymphoma and leukemia before undertaking a fellowship in retrovirology with Professor Courtenay Bartholomew, during which he fondly recalls as the golden age of retrovirus research from 1986 to 1990. Dr. Cleghorn's academic pursuits continued with training in internal medicine and infectious diseases, culminating in a fellowship at the U.S. National Institutes of Health, NIH, at the National Cancer Institute. His academic achievements were further bolstered by a Master of Public Health in Epidemiology and Biostatistics from the Johns Hopkins School of Public Health, where he was inducted in the Alpha Delta Omega Honor Society. His professional journey led him through significant roles at esteemed institutions such as Johns Hopkins University and the University of Maryland Medical Center / Institute of Human Virology. At the latter, he served as assistant professor of epidemiology and prevention from 1996 to 2004, fostering extensive collaborations with the Medical Research Foundation of Trinidad and Tobago and the University of West Indies, where he also served as an internationally respected health diplomat. Dr. Cleghorn's impact extends far beyond academia. As the global head of health at Palladium until his retirement in June 2024, he led interdisciplinary teams across the US, Europe, Middle East, and Australia, the Pacific, pioneering transformative health programs. His work spanned strategy, execution consulting, international consulting, impact investment, and training, focusing on sustainable health systems, implementation science, and health promotion. Throughout his career, he has been recognized as a thought leader and systems thinker in global health systems, population health, HIV and AIDS, infectious diseases pathogenesis, and clinical vaccine trials. His expertise earned him numerous accolades, a nominee for the SEA Crystal Award in Spain and a winner in the Gabriela Award in Chile, including the Chancellor's Award for Excellence in Global Health Research and Delivery in 2023. That's just last year, folks. Beyond the professional achievements, Dr. Cleghorn's philanthropic endeavors underscore his commitment to medical education and community welfare. His generous donation to the University of the West Indies Medical Alumni Association established an endowment for scholarships reflecting his dedication to nurturing future medical professionals. His impact on global health is not only evident in his scholarly contributions, but also in his humanitarian efforts. He has mentored countless young health professionals, contributed significantly to global health diplomacy. His compassion and dedication to improving healthcare, especially in underserved communities like his native Trinidad, exemplify his profound commitment to humanity. In sum, Dr. Farley R Cleghorn's career is a testament to the transformative power of medicine and public health, driven by a steadfast belief in the potential of healthcare to enrich lives globally. His legacy as a scholar, mentor, and advocate for equitable healthcare continues to inspire generations of healthcare professionals worldwide. As Chris Legrand, Chief Executive Officer at Broadreach Group, who has known him for 20 years, serving alongside Infutures Group, now the Palladium, as Chief Technical Officer, accomplishing many things together, said, "More than his brilliance and professional impact, what I've come to love of Farley is his heart. Farley has a heart for humans and our human condition. Where others see only human tragedy and despair, Farley sees community and possibility." Farley Cleghorn. But before we get to the questions, I want to introduce you to Farley's book. This is something that was just done upon his retirement, and one of the things that celebrates 20 years of dedication by the company that he headed. And one of the things that he was involved in, and look at this picture, he was very active in the COVID 2023 pandemic that we all went through, and look who he's proudly standing with, or who is standing with him. So this is just part of who Dr. Farley Cleghorn is. 20 years dedication. And now we're going to get into the questions. All right, so Dr. Farley Cleghorn, first question for you is, what are your thoughts on the World Steel Pan Day? Not to throw you off or anything.
Well, first of all, Ozzy, can I say what a pleasure it is to have you in my house.
Aww.
And I'm enjoying this immensely.
Thank you.
World Steel Pan Day. I don't know if you know Kim Johnson, but he wrote an amazing book on pan. And it's right here, actually.
I'm going to check it out.
And he's really a journalist and writer in Trinidad. But I learned so much about pan and its history and the sort of social nature becoming the national instrument. That World Steel Pan Day, go for it.
How do you see the role of steel pan evolving over the next decade, both like in terms of musical expression and cultural identity?
You know, to me, one of the challenges is moving from what's a niche instrument with a lot of novelty value to something that's acknowledged as an instrument in orchestras around the world. I don't have an answer for that. How is that going to happen? I think it's been slow, and even in the place where it originated, I think no one is quite sure beyond the current expressions of how to do that. I'm not sure.
Okay, so now with that, I'm going to ask you, can you share a pivotal moment early in your career that shaped your path in global health and infectious diseases?
Sure. Well, when I was a very young child, I wanted to be a veterinarian. Why? I'm not sure, but it appealed to me. And
did you have a lot of animals around you at the time?
Oh yeah, my dad was a member of the TSPCA, and we would have to go clean out kennels, and of course, remember the little book called Little Folks Trinidad? Well, to me, that was a gold mine, and I inhaled the whole thing. I think I was a bit more aware, perhaps. You know, in those days, there was not the environmental craze there is today. People wanted to beat back the bush. I wasn't sure that was something you needed to do. I wanted to go into the bush. I doing medicine, it's kind of one of the professions in the Caribbean where bright young people are channeled. And so initially I resisted that idea. I wanted to be a writer. And I remember very clearly that Presentation College, San Fernando, could not get a literature class together. We couldn't get 4 people to do literature at A levels.
Wow.
We had enough for economics and history, but no literature. So I went into science. That was a
Wow.
that was a very
I
sort
would
of
say that's pivotal.
that's pivotal, yeah.
Wow. How did your experience actually at UWI influence your approach to medical research and practice?
UWI was an amazing experience. First of all, I have to say it wasn't my first choice. I wanted to go to the UK. There was always this thing about going to the UK. But Margaret Thatcher put an end to that because she changed the fee structure so that Commonwealth citizens who, until that point, had the same fee structure as Brits, they had to pay 5 times more.
Wow.
Yeah. So in 1977, when I was applying to medical schools, I got into a lot of British schools, but I could not put my parents through that kind of expense. And so UWI was my fallback option, but it turned out to be one of the best things that ever happened to me because I became a Caribbean person. It is still today one of the enduring Caribbean organizations. And it makes you a Caribbean person in a really amazing way.
Can you describe your role as Assistant Professor of Epidemiology and Prevention at the University of Maryland Institute of Human Biology? And what was some of the highlights and challenges you had there?
Sure. So you have to throw yourselves back, and certainly I have to throw myself back to that point of my career. I was leaving, I had been at the National Cancer Institute doing my fellowship, which is where I first met Tony Fauci, actually. And that was 1990. I stayed on in the viral epidemiology group as a visiting scientist. And in 1995, Bob Gallo, who was one of my bosses, so it was Tony Fauci, Bob Gallo, and Bill Blattner, and also Sten Vermund. These are big names.
Yeah.
And Bob Gallo retired from the U.S. Public Health Service, and the state of Maryland offered him $200 million to start a new institute devoted to studying retroviruses. And HIV is a retrovirus. So the notion that you would have what we called a bench to bedside organization where we had patients, we had the lab, and we had studies around the world. We put all of that together. That is what took us to the University of Maryland. That's what the IHV was. And it's still going today. And Bob Gallo is still the head of it. And he's approaching like 88 years old. Wow. So that was, it was just an amazing thing to be part of. I was one of the first 5 people to start that new institute.
How did that happen? How did you get in front of them, sort of?
Oh, because I was part of Bob Gallo's group at the National Cancer Institute. So that's how I went with him.
What were some of the challenges that you had?
Well, the challenges were, first of all, entering a state university system. You know, the University of Maryland system is one of the most sort of complex in the United States. It has the oldest school of dentistry in the United States, and one of the oldest schools of pharmacy, and one of the oldest schools of medicine. So you're entering into a very, shall we say, well-established order, and then you have to break it all down to put in this big new institute that a lot of people were I wouldn't say they were jealous, but they were like, oh my God, they gave them all this money to
Right.
start this new institute, a whole new building on Lombard Street. And it was wonderful, actually,
So you didn't
because
have many challenges.
I wouldn't say that at all. We had many, many challenges.
I'm talking about you personally, though.
Personally, I embraced it all. I was young and energetic. I loved the idea of bench to bedside. I loved the idea of teaching, which I always have and always do. I taught all kinds. First of all, we have to say that at this kind of institute, teaching occupies the lowest rung on the status scale. But to me, it was one of the most important things I could do, where you teach incoming medical students, you teach residents, you teach fellows. It's just an incredible thing, and I enjoyed that immensely.
What motivated your transition from clinical practice to a focus on public health and global health systems?
Well, it was the AIDS epidemic, really. AIDS was causing devastation around the world. And luckily for us at the Institute of Human Virology at the University of Maryland, we were one of the big players in the US landscape. And so this was in the early 2000s when George W. Bush became president. The Congressional Black Caucus got him to agree to fund a global program to mitigate the impact of AIDS, particularly in Africa. And that program was called PEPFAR, is called PEPFAR, it's still going, the President's Emergency Plan for AIDS Relief. And we were invited in as part of the technical architects of the PEPFAR program. And it, of course, identified and gave out funding to help countries around the world, particularly those with big HIV epidemics, most of them in sub-Saharan Africa. Right. And I was able to see a pathway. We had already been collaborating with a technical group in DC called Futures Group, which was a global consulting group, small at the time, very technically focused, primarily in modeling and forecasting of infectious diseases. And I, of course, I'm very eclectic, as you can see. Because of my biostatistics experience, I was also interested in modeling and forecasting. And at the same time, I could help countries to mitigate the impact of HIV. And that's what brought me from the University of Maryland to Futures Group in 2004, April 16th.
You have had extensive involvement with HIV and AIDS research and clinical trials.
Yes.
What breakthroughs or achievements are you most proud of in that field?
Well, when you talk about medical research, you can labor at the frontier for years and years and make very few breakthroughs. So I want to start with that because we're still looking for an HIV vaccine. We're still looking. And it's been 30 plus years of doing that kind of work. That means you have to, first of all, have the products that could be tested as vaccines. So there's a lot of basic science going on to identify those potential vaccines. Then you have to test those vaccines in clinical trials, and it's a long process. Phase 1, phase 2, phase 3. And you have to interest people who are not HIV infected to test a vaccine.
But, I look now at what has happened with COVID and SARS and whatnot, right? In 2023, all of a sudden, things happen like this.
Yes.
Boom, boom, boom.
Well, amazingly.
Why isn't it, can it happen with?
Because it's accretive, essentially. Medical research learns from what went on before. And much of what we learned for COVID, we had learned for other viruses. Remember, COVID was not the first coronavirus that we encountered. Right. We had two other coronavirus
Right.
and epidemics. One was SARS,
Right.
severe acute respiratory syndrome. The
Right.
other is Middle East respiratory syndrome. So we had a lot of research that was applicable to the new SARS, which is SARS-CoV-2.
Right.
And so many of the advances were able to be pulled together very rapidly for COVID.
But it's the same thing with AIDS, isn't it?
No, it's not.
No, it's not.
It's absolutely a different kind of virus. So HIV/AIDS is a retrovirus, and we only have 3 examples of them in humans: HIV-1, HIV-2, then HTLV-1 and HTLV-2. And those have no cure. We now have treatments that can hold the virus in check,
Right.
but cannot get rid of it. That is the thing. So sterilizing immunity is the challenge that we have not yet been able to meet, either in clinical trials or in long-term treatment for HIV.
So do you see that there's anything coming soon that there would be a cure? I mean,
Yes, there is a large body of work that aims to use better and better treatments so that you reduce the amount of HIV in the body down to its very smallest
That's
quantum.
what they have now, where things are negative, right? Is that the same thing?
So in other words, the better your treatment, and usually we use multiple types of treatments in the same protocol.
Right.
The better you do that, the smaller the pool of HIV in the body.
Right.
And so that theoretically, once you get that pool down to effectively 0, becomes a cure. But unfortunately, that is not yet the case. The case is, even with excellent treatments, once-a-day formulations that produce absolute normal health, if you stop taking it, it comes back. Yeah, that's unfortunately the current situation.
As the global health of Palladium, what were the most significant challenges you faced in leading health practice across diverse regions, like, all those countries you visited, US, etc.?
Visited and lived in.
Lived in.
First of all, there's a community of organizations that do this kind of work. They run the gamut. They're big ones, small ones, for-profit, not-for-profit, charities, non-charities. It's a community, and they're all interested in balancing the inequities that exist in the world. If you have a heart attack in DC, if I have a heart attack tomorrow and I call 911, they're going to come get me right away. They're going to take me to a cardiac center. I'm going to have all the appropriate investigations, and my chances of surviving it are actually excellent. Mm-hmm. If I have that same heart attack in more than 70% of the world, that's not going to happen. My likelihood of death is going to be huge. So when we talk about health globally, we talk about the inequities of the experience of health, whether you have chronic diseases like that heart attack I just mentioned, or you have infectious diseases like the HIV we were just talking about, or you have just health promotion, which is, how do I get the best healthy years out of my life? Right. We have inequities across the board, and those inequities stem from many things. One is, of course, wealth. Mm-hmm. Wealthier countries can build better systems. Mm-hmm. But it's not an exact relationship. Mm-hmm. There are many middle-income countries that actually do better in general in health than the United States. Mm-hmm. And that's because they have a public health-oriented approach, mm-hmm. which is do the most good for the most people. And we do not have a public health-oriented approach in the United States. We have give them the best medicine you can find approach. Right. That doesn't always result in the best population gains for health. So it's a globe. There are over, well, it depends on how you count, but there are 203 Olympic committees in the world. That amounts to about 190 something recognized countries. And all of them have health systems. All of them are trying to preserve the health of their countries, except the ones that are in utter chaos. And many of them have differential results. So if you take only the wealthy countries of the world, like the 32 members of the OECS, the US actually comes down at the bottom in terms of health achievement, because you're looking at the average experience. And that usually has to do with childhood health, pregnancy health, chronic disease management, mental health, and just get up and go. And we in the US are much better at finding the newest drug, doing something very complex. We can transplant your heart any day, but is it going to keep you alive longer? That's not as important. So anything of complexity we can do in the US really well. Anything that will preserve the lifespan of the majority of the population, we don't do so well.
Great to hear. Can you discuss a particularly rewarding project or initiative you led at Palladium that had a significant impact on public health outcomes?
Sure. I mean, there are many, but we talked about the fact that it's not just about health and medicine, but the approaches you use to deliver better health to populations. And one of the ways in which we do that, we always talk about when you invest in health, you want more money to invest. Also, you want more health for the investment. So you want more return. And finding ways to get that return depends on all kinds of complexities when we think about how money for health flows around the world. And so one of the things that we had been working on and still working on for many years is called innovative financing for health. That means, how do we get more money for health? How do we get more health for the money? And how do we make that more efficient, the getting of the money and the using of the money to improve health? And so there's something called impact bonds, which is, there are two major types: development impact bonds and social impact bonds. And Palladium designed and implemented the first major development impact bond in India. It's called the Utkrist Development Impact Bond, funded by the US government and invested in by UBS, which is a Swiss bank, and implemented by Palladium. And that was the test case for using that kind of approach to invest in maternal and child health in Rajasthan, one of the Indian states. And it's still today the best case scenario for how to accomplish that.
How do you see the future of global health evolving, especially in the light of recent challenges like COVID-19? Kind of getting back to what we discussed a little bit before. Really want to know more about that.
Well, you have to think of it in the context of everything else that we have to face today. COVID-19 was our first real social media pandemic. Well, first of all, it was a 100-year pandemic. Okay. It affected literally the entire world, and it gave rise to all kinds of what I call new phenomena, such as the use of social media not just to promote the response, but to tear down the response. And it centralized groups of people who ordinarily would have been at the periphery of health. People like vaccine denialists, or people who think that the government is out to get them. These suddenly assumed positions of importance within communities. because everyone has a platform to say what they want to say. So there are many, many factors at play in how COVID and the impact of COVID, even though you'd be forgiven for thinking right now that no one remembers COVID, right? Nobody wants to talk about
correct.
COVID. Nobody's interested in talking about COVID. But amazingly, depending on where you are, COVID either improved public health for the future or it sent it backwards. And I have to say that in the United States, it went backwards because we have less public health professionals today than we had before the pandemic. We have less funding for public health today than we had before the pandemic. We have weaker institutions today than we had before the pandemic. This is one of the great contradictions of the United States.
Do you see within the next election that
this will change?
Yes.
I think certainly the government matters. Who's in government matters because they can prioritize public health. And Democrats prioritize public health.
Right.
At the same time, I'm talking about at every level of government.
Yes.
Not just who the national government is.
Right.
I'm talking right down to county level.
Correct.
Which is the least, when I say least, it's the smallest but most important government entity in the United States.
And the reason I asked you that too is because this has kind of pulled back the view to those different levels.
Yes.
So that the new, hopefully with all that exposed, that things would be implemented now based on the weaknesses, right?
Yes. In other words, when I was training, and for the last maybe up to 10, 15 years ago, politics and public health never mixed.
Correct.
Today,
yeah,
public health is politics.
Right. And that's why I asked that question. Do you think that there's a chance that those things that are being viewed now, there's a chance that they can be amended, things can be amended?
I always live in hope. I tend to see the positive. I think people who have knowledge and knowledge itself will carry the day. But countries can go backwards for quite long times, and that, unfortunately, is the human experience. So the national government's very important to lead the way, but we have to help, the man in the street and the woman in the street understand that, that's the best investment they could make is public health.
Right. So, with that said, what advice would you give to young professionals aspiring to make a significant impact in global health and infectious disease research?
Yeah, I would say that we're talking here from a general medical standpoint. No field stands still. People always talk about golden ages in whatever field you're in. I feel that, there were golden ages in how we practiced medicine. Today, it's quite different. I'm not saying it's worse. I'm saying it's quite different. Some of it is much better. For example, the way we incorporate the opinions of the patient or the person in front of us, because they're not always patients. They could be clients. In other words, a client is before someone gets sick. When they're sick, they're a patient. And we never really considered the needs and wants of the patient. Today, the needs and wants of the patient are paramount in how we practice medicine. But there are many other factors at play that may make the experience worse, such as the focus on costs.
So your advice to these professionals would be?
That you have to try to understand all of medical practice, not just I became a doctor because I know how disease happens and how to treat them. medicine is inherently a social enterprise. That's what it is.
That's the first time I'm hearing that. Even though there's truth in that, it's the first time I'm hearing it like that.
Well, there you go. You came to the right place.
Well, looking back at your career, what legacy do you hope to leave in this field of global health and infectious diseases?
Well, I think, there's what's called the hard literature, the stuff that you write, that's printed, that people can reference. And then there's the gray stuff, the stuff that you do, the service you give to the community. And when I say community, I mean the medical community, and how that evolves. And then there's impact. You can use resources to further impact your own resources. You can undertake what I call direct action. Direct action, everyone is capable of, which is I get up in the morning and I say, what can I do today that will make things a little better? You go volunteer, you go give your service, you help other people, you teach young people, you do all of that. That is direct action. And, writing a check is one thing, but direct action is really satisfying.
Can you explain the difference between a pandemic and an infection for those of us who may not be ignorant of the two?
Sure. So an infection is caused by an infectious agent, an organism. And there are many, many families and types of organisms. And when, for humans, the medically important ones, because there are a lot of organisms that cause nothing in humans. Okay? In fact, without organisms, we would just die. In your gut alone, there are 7 pounds of microorganisms, and you couldn't live without them.
Right.
Okay. Every part of your body has its own biome, which is the mix of organisms that live in your eyelids, on your lips, and your fingers, in your genitals, in your gut.
Right.
There are few sterile parts of the human body. The brain is one of them. Okay.
Give me another one. I'm curious.
The bladder.
Another one.
Your heart.
Wow. Okay.
Yeah.
All right.
So just the understanding that you have to have an organism. The organism, when it's important for humans, can cause an infection, and that infection can be serious or non-serious. You can say, well, I got a summer cold. Well, it's the same process at work. You've encountered a virus which infects you and causes the symptoms of a summer cold.
Right.
There are organisms that are deadly, that will kill you. We talked about AIDS, for example. It kills you in a long period. There are some that will kill you in a very short period, like rabies. Okay, these are all organisms. Those are, when they occur at the same time, you have outbreaks. And an outbreak is an epidemic. An epidemic is defined as more than the expected number of cases.
Got it.
Okay? So if you're talking about summer colds, you expect a few million of them in the United States. If you're talking about rabies, you expect 0.
Right.
So one case is an epidemic. And a pandemic is when multiple countries around the globe experience the epidemic together.
What was your role specifically with this pandemic that we went through?
Sure. So, as we have said, when the pandemic started in January of 2020, I was global head of health practice at Palladium, operating in over 90 countries. And when a pandemic starts, first of all, you have to recognize the pandemic.
But wasn't it really in 2019 that it started?
Yeah, it started in 2019, but it wasn't declared a pandemic until March of 2020.
Yeah.
So that's the whole point. Between the last weeks of 2019 and January of 2020, all kinds of global alert systems were going off. And those were primarily infectious disease networks saying there's an unexplained respiratory illness in China.
Right.
I gave my first COVID talk on January 19th of 2020. because I was part of those networks,
Right.
we had not yet declared anything in the United States.
Right.
In fact, nobody had declared anything. It was
Correct.
simply a phenomenon that was being recorded.
Right.
And so, as head of a health practice that covered over 90 countries, where we're helping governments, our first duty was to warn governments.
Right.
Our second was to understand how, remember, we didn't have a test for the first 5 months.
Right.
Our own CDC tried and failed at implementing a test.
Right.
Many companies came to the rescue. It was actually quite easy to make those tests. The difference was being accurate.
Right.
Okay. And so over the first 6 months of 2020, an organization like mine and a health practice like the one I led did many, many things. Prediction and modeling, so forecasting, understanding who to test, understanding what to do if someone's positive, understanding what the plan is at the country level and at the local level, because country plans have to be implemented locally.
Mm-hmm.
And yeah, I would say the first 6 months of 2020 was absolutely crazy. Mm-hmm. And I mentioned earlier when we were chatting that the first request I had to explain what the hell is going on was, and there were many people in my situation who are infectious disease epidemiologists who looked at the data and said, here's where we're heading. And so Bloomberg News called me in March of 2020 and said, would you come on and explain to us what is going on? Mm-hmm. And that was the first of, it seems like hundreds of interviews mm-hmm. that I did over the course of the pandemic. So one of the critical roles that doesn't get a lot of recognition is how do you explain to people in language they can understand what's going on?
And where do things stand now? Because, okay, the last, when I'm in groups, on a bus, on a plane, I'm masked.
Yeah.
There are a lot of people who think it's done.
Yeah.
But I think since this, I'm a little more in tune maybe, but when somebody like the president gets COVID, then all of a sudden people are calling me and saying, hey, blah, 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 blah. What is the journey of COVID presently? Where are we?
COVID is exactly where we predicted it would be. Mm-hmm. It's become an endemic mm-hmm. respiratory virus. So circulating in the human population, mm-hmm. as opposed to epidemic, which is new to the human population, and we're not quite sure where it's going to go. And by being endemic, it joins a group of viruses, respiratory viruses, that circulate within humans around the globe. Mm-hmm. And it's seasonal. Interestingly, the seasonality of COVID is not quite the same as other winter-focused viruses. Mm-hmm. So right now, we have a summer outbreak of COVID going on. As mm-hmm. you just said, Biden had COVID. Mm-hmm. Because of background vaccinations, mm-hmm. The impact of this virus is really quite mild, mm-hmm. except if you are over the age of 65 or 70, or you have some kind of severe immunocompromised state. Mm-hmm. So it's, while people may think it's not important to get vaccinated, mm-hmm. it still is. Mm-hmm. And there'll be a new vaccine coming out in late September, October, that focuses on the predominant circulating strains of COVID, because there are always multiple strains. Mm-hmm. The strains are evolving.
So is that going to continue happening?
Yeah, that's exactly how we think it's going to keep happening, at least for the foreseeable future. COVID is not going to disappear. Right. It's one of the many circulating respiratory viruses today. It's become endemic.
So I met somebody recently who said to me, "Oh my gosh, I had COVID. I didn't have it all this time, and now I got it.
Yeah.
But my symptoms, because I was vaccinated, severe headache for maybe 3-4 days.
Yeah.
But she still stayed away from others for 12 days or something like that."
Yeah. I would say that while we're not offering a national testing program anymore, it's still important to understand when you're attending large gatherings, if you're going on a plane or you're in any crowded situation, you can still protect yourself by wearing a mask, by avoiding contact with too many people. And if your state of health is such that that's important, you should do exactly that.
And it's the symptoms are going to be different per person, right? So
Yes.
one person may have the headache,
Yeah.
another person may come down.
Yeah, there's what we call a constellation of symptoms, and you're going to have some of those.
Right.
There are very few people who have all of them.
Okay.
Yeah.
Anyway, has your cultural background influenced your approach to healthcare and community engagement?
You know, that's a really interesting question because I used to say no. But now I think age brings a little more wisdom. Now I realize that in the Caribbean, we inherited this British grammar school thing. And it was a very boy focused until it became boy and girl focused. But when I was growing up, if you were a bright boy, you know, you had a lot of attention. And that attention led you down a certain path. And so definitely that's a cultural influence. And it sort of pushes you along. And then there's the whole notion that the Caribbean is, it's a crossroads. You know, everybody showed up, everyone left their mark, everyone is still trying to figure it out. And that gives you a certain amount of social skill. It allows you, in a very diverse setup, to understand when to get up and speak, when to represent, when to step back, when to consider other people's opinions. You know, it gives you a set of social skills coming from the Caribbean.
I hear that pride. I hear that pride. I feel that pride. It's impactful. Thank you very much. You got that, folks? Thank you, thank you, thank you, thank you, thank you, thank you, thank you for being here. Thank you for being on the call. Thank you for checking out Dr. Farley Cleghorn. And we want to thank the Frank and Myrtle Cleghorn Foundation for their support. Really do. And for you, for hanging in for the after show, which is coming up. So you'll get to know a little more about Mr. Cleghorn here, Mr. Farley Cleghorn, Farley R Cleghorn. And the other thing is, I want to thank you for these past seasons of On the Call. I want to thank our team for being with us, working on it. Here on this site, we have Cheese Slice Films, aka Kevin Tinsley, who is now a nominated Emmy Award winner. I'm going to put that name in there. But don't forget to like, follow, share. Be with us on Inside the Call. And again, as I always say, when you're on your beat, stay on the sunny, sunny side of the street. Be health conscious and kind to one another, and don't forget to give thanks for the little and big gifts as we strive to a beautiful life. See you at Inside the Call with Farley Cleghorn coming up real soon.